Hello, and thank you for joining us today for this live social media event during this National Cytomegalovirus Awareness Month. I'm Dr. Natali Aziz, a clinical associate professor at Stanford University School of Medicine in Stanford, California. And joining me today, we have two experts who've spent decades researching, advocating, and treating patients with congenital cytomegalovirus, a condition in which the fetus is infected with CMV in utero during pregnancy. First, we have Dr. Mark Schleiss, the American Legion and Auxiliary Heart Research Foundation professor at the University of Minnesota Medical School in Minneapolis, Minnesota. He's been a pediatrician for over 40 years and has spent the last 2 decades treating babies and children with congenital CMV. And most recently, he has been the driving force behind getting Minnesota legislature to pass the law in which CMV was added as a universal screening test for newborns, making the state of Minnesota the first state in the United States to screen all newborns for congenital CMV. A huge, huge win. Next, Dr. Geeta Swamy, the Associate Vice President for Research and the Vice Dean for Scientific Integrity, as well as the Haywood Brown Distinguished Professor for Women's Health at Duke University in Durham, North Carolina. She has achieved international acclaim as a clinician researcher and expert in the field of maternal immunization and perinatal infection, including congenital CMV. Welcome to the both of you. And before I dive into the questions, I'd like to briefly review congenital CMV for our audience members who've joined us today. Cytomegalovirus is a common virus that's part of the herpes viridae family and is spread through almost all bodily fluids, including saliva, urine, and blood. Anyone can become infected with CMV, and fortunately, most people will have no symptoms or consequences that are adverse from this infection. In some countries, such as Brazil and India, over 90% of people have been infected with CMV in early life. This means that they have a seropositive status for the virus. In the United States, it's estimated that nearly 1/3 of all children have been infected by the age of 5, and over 1/2 of the population has been infected by the age of 40. Now, for most people, CMV infection fortunately has no impact. But for some, like those that are immunocompromised or the developing fetus in utero, the clinical manifestations can be quite substantial. We're going to focus on congenital CMV and how we increase awareness in hopes of reducing the risks of acquiring CMV during pregnancy in our discussion today. And Mark, I'd like to start off with you. Let's first take a look at the numbers. How many babies are born in the United States with congenital CMV infection annually?
Well, current estimates are that there are somewhere around 20,000 babies born in the United States every year with congenital CMV. It varies a lot from one region of the country to another, but about 1 baby in 200 is born with this infection. So in the scope of the things that we encounter in clinical practice, it's actually fairly common. We screen and have screened for decades for diseases that are much less common than CMV.
That's astounding. And what are the symptoms of congenital CMV in newborns?
We only have identified in the past kind of the tip of the iceberg, the sickest babies. And the sick babies are recognized by most care providers. They're babies that are born with unusual skin rashes, what we call petechiae or purpura, enlargement of the liver and spleen. Sometimes if a baby is infected early in gestation, the brain can be injured and the baby is born with a small brain. We call that microcephaly. But it turns out that maybe as many as 3/4 of the babies that are born with CMV, we don't really know it at birth because they seem normal and seem healthy. But we want to identify these babies in the future because even in that group of babies that look normal at birth, up to 15 or 20% of those babies may have hearing loss, which isn't present at birth. It may progress after birth, and that child may lose his or her hearing in the first couple of years of life. So that's the key, finding those babies so that we can monitor them very closely and be prepared to intervene if they are one of those babies that develops hearing loss.
I agree. That is quite impressive. And now that we've talked about the symptomatic newborns, what about the asymptomatic ones, the ones who test positive for congenital CMV but don't have symptoms? What's their course like?
Yes, and so those babies, again, are at risk to develop hearing loss later in infancy or childhood. Maybe as many as 50 to 75% of the babies that are asymptomatic and here normally at birth will have hearing loss that develops over the first 1, 2, 3, 4 years of life. They need to be monitored closely. And we know that if a baby has hearing loss and it's not detected by the family or primary care physician in the first 3 years of life, that can have permanent influence on your speech and language development. So that's the most important thing is identifying the asymptomatic babies, knowing that some of them will go on to have hearing loss and being prepared to monitor them very closely.
Excellent. Thank you. Now, focusing on Geeta, I will ask you to help us understand about building awareness of congenital CMV. Geeta, what do we know about the risks and burden of congenital CMV before and during pregnancy?
So there are a couple of factors that influence the risk, really, of the complications related to congenital CMV during pregnancy. If the pregnant person has been exposed to CMV, periconception or prior to pregnancy, versus if it is at the timing of periconception or during early pregnancy, those two sort of pictures of CMV infection look very different. It's really important to know if it's during pregnancy when that happened as well, because when it's early on in the pregnancy, say in the first trimester, then it can be much more significant with regards to the severity or complications that might occur. When I mentioned before, Natalie, that if it's prior to pregnancy versus during pregnancy, in the clinical world, we often will talk about that as being something we call primary versus non-primary infection. And in the primary infection state, the best way to think about that, or as I sort of talk about with patients, is say, this is the first time you've ever had CMV as an infection or gotten the CMV virus. And it really means that if you can demonstrate through testing that someone has gone from having a negative test to a positive test. So it's really important to realize that, because just a positive test alone doesn't tell you if it's infection now, or if it's what we call non-primary, which means it could be reactivating latent virus or getting reinfected with a new strain. And again, the reason that that's important is really to think about the implications of the CMV infection in the fetus, because it is the most significant if you have primary infection during the first trimester of pregnancy. It's important, though, to note that not all primary maternal infections in the first trimester will lead to placental passage of the virus across the placenta to the fetus. But the risk of transmission to that developing fetus is really probably around 50% if that occurs in the first trimester of pregnancy. This is why, as we keep talking, it can seem very complicated, because what we'd like to know is that you have a test and you know what that means. But in this situation, if you have a test and then I say to you, well, it's about 50% chance it could get to the fetus, then you're sort of going, that's difficult to really grasp, I think, for both providers and patients. But if that transmission does occur, that the infection passes from the pregnant person across the placenta to the fetus, it can be quite devastating, as this is when disease severity or risk of fetal complications is highest in the early part of pregnancy. We know that, as Mark mentioned, there can be significant impact on neurodevelopment, or how the brain is developing in the fetus. And it can have other impacts across the fetal development, as far as the rest of the fetus, as far as growth and that sort of thing as well.
So is it fair to just say that, in summary, the earlier the infection occurs in a pregnancy, the more adverse the sequelae or severe the sequelae will be for the developing fetus?
That's right. The earlier in pregnancy that the first infection ever occurs, I think, is associated with the worst outcomes that we've seen.
Thank you for that clarification. Thank you. Geeta, now, can a person test their CMV serostatus to see if they have been exposed prior to becoming pregnant? Is that even available or possible?
Yeah, it actually is. This is something that came about probably in the last 10 years or so, right? That we can do what we call in the days that I trained, we did just CMV testing with antibodies, and we would do what are called IgG and IgM antibodies. And we know that now we can add an additional test that actually can help us know how recent or how remotely past that infection might be with something called IgG avidity testing. And that basically tells us how mature or immature that IgG antibody is. If it's very sticky or high avidity, then that means it's probably old. It's been around a long time. But if it doesn't, then it means it's probably pretty recent or new. Having said that, though, at present, we do not routinely recommend serologic screening for all pregnant people in the United States, at least.
Correct.
We only recommend that under certain specific circumstances that might have to do with exposure. And again, part of the issue is that maternal screening will not tell you if the fetus has been infected or not, right? It can give you clues, but doing it across the board without knowing what the other circumstances are is why we don't recommend universal screening right now.
Now, when determining or assessing if a pregnant person has been infected and if it is a primary infection, is the DNA PCR and the level helpful? I think there's been some new studies to demonstrate that maybe the level of the DNA might be implicating the higher risk for fetal infection, for example.
Yeah, so it gets back to things like viral load, right? And that is a terminology that we, have used pretty regularly in things like, say, in HIV and in hepatitis, where we talk about the viral load being associated with how significant the disease might be at the time. So as Natali mentioned, you can diagnose things in the fetus through ultrasound and amniocentesis, right? You really kind of need both. Ultrasound can help you to look for symptoms or signs that the fetus might be infected. We might see things like growth restriction, where the fetal size and weight is lagging behind the gestational age we expect it to be. We might see sort of bright areas in the bowel, which we call echogenic bowel. We might see those in the brain and the liver, other brain abnormalities as well. Amniocentesis is really helpful if it's also done at the right timing. And why I say that is because it does take time for the virus to grow from the pregnant person into the placenta, replicate or reproduce in the placenta, cross into the fetus. The fetus then actually has to replicate that virus and excrete that virus right into the amniotic fluid, which is through fetal urine. So that doesn't happen in an instant and actually takes many, many weeks. And so it is important to note that timing of amniocentesis is important to be able to anticipate how long that might be, because what you don't want to do is go through the amniocentesis, which in itself has some risk, even though that's small, a pregnancy loss, only to get a negative test that might be falsely reassuring to a patient that continues going forward with things under the presumption that it's CMV negative, only to find out that it actually is CMV positive. So those are the kind of things that it's important for providers and patients to make sure they're on the same page and understand those things as well.
Excellent. Thank you. And what's that general recommendation of how long does a pregnant person have to wait from their infection to undergo an amniocentesis? What would be a successful time period for that?
Yeah, so if it's early pregnancy, like first trimester, then you're usually looking somewhere around 20 to 22 weeks for doing that amniocentesis. Again, trying to track back to when that might have occurred, when the infection might have occurred. One of the things we also didn't exactly touch on, Natali, is that CMV infection itself, even primary infection in an adult person who doesn't have any other medical problems or reason for their immune system to be impaired, may not know they have CMV at all. And so that's the other part that can be difficult, is that trying to track back when they might have had it. They might not have had any symptoms, or they might have had the common cold like I feel like I'm getting over the last few days. And so then they don't really recollect that they were all that sick to be able to even attest to when that might have been.
Right, right. Great. Thank you so much for summarizing the diagnosis of a fetus that may be infected with congenital CMV. And now that takes me to my next question, which is, Geeta, what can the obstetric provider do when caring for a pregnant person with congenital CMV? What are some of the general guidelines and advice that you can give our obstetric provider colleagues that are here and our audience members?
Yeah, absolutely. I mean, I think, first and foremost, we need to figure out how to be as supportive as we can to the patient and their family. Um, it's important to remember that we should acknowledge what we know and don't know, what data we have that we can present to support options and decisions, and what might be in a position where we're trying to help patients, assist them to make decisions where we don't really have all the answers. So why I say that is because we know that support may come in the space of providing specialist care, access to other people besides us as obstetricians to talk to, folks like Mark in the pediatric space, people in the pediatric infectious disease space, in the newborn nursery or neonatal nursery, in the area of sort of supportive care or special care needs that an infant with CMV might need. I think it's also important to note what the additional care for the pregnant person may look like following a diagnosis. Natalie, you and I obviously see patients and routinely order ultrasounds, but it's important to note an ultrasound that might be in this space, right, really should be detailed ultrasound or involve maternal fetal medicine care to be able to provide guidance on timing of delivery and whether they're making sure all the right tests are done and so forth. And making sure we're pointing folks into the right direction for advocacy. Mark, I think you may talk about this later, but other support networks and so forth that are available for our patients and their families. There are, a lot of discussion comes into play certainly about when a patient might say, well, Dr. Swamy, what can I do? What can we do? Is there something we can do now? There have been studies, again, talking about the complexity of CMV, studies looking at interventions during pregnancy. There are studies looking at treatment of the newborn. Right now, the treatment studies during pregnancy, for example, one thing has been with regards to giving something called intravenous immunoglobulin. That has actually been proven to be ineffective and actually may have other concerns with regards to timing of delivery and so forth. So we really do not recommend that. There have been some early studies, although small and needing to be replicated with regards to other antivirals, acyclovir. But there are also some concerns with that for maternal health. There have been complications related to that likely because of the high level of dosing that is needed. So I say that to mean that we should not simply say to a patient, we don't know, we have nothing, because we know that they are going to go on the internet, they're going to look for things, they're going to ask other people. So we should be prepared to have those discussions. But also prepared to talk about what we don't know, and that some of this decision making might not be ready yet, right, to move forward with some of those treatment options.
Thank you. That was an excellent summary. I really appreciate it. Mark, I'd like to now shift our discussion to you, and you're being an expert in this, and to discuss universal screening. Where are we now with respect to universal screening of newborns for congenital CMV in the United States?
Yes, it's a very good question. I think we have a slide that will summarize that. And this slide shows the one state in the United States where there's active legislatively mandated universal screening, and that's right here in my home state, Minnesota. This was the product of several years of lobbying and legislative initiatives, a lot of false starts and stops, a lot of roadblocks along the way. But after several years of fighting hard for this legislation, we got it passed in 2021, a bill called the Vivian Act, and it led to a budget allocation to help fund universal screening of all newborns for CMV, and also a commission to the state health program to study the problem give a recommendation to the Minnesota Health Commissioner, which happened in late 2022. And so as a product of that legislation and that study of the issue, in February 2023, we began screening all newborns. The way we do it is to collect some punches out of that dried blood spot card. Every parent knows about that heel prick that leads to the collection of blood spots on the filter paper. We just punch a couple of widgets out of that blood spot card and test it for CMV, and that is the screening test, which then leads to a definitive diagnostic study to see if the newborn's infected. Now, if we go back to the map for a moment, I do want to just comment that New York State is also screening all newborns. This is currently being done under the aegis of a NIH-funded study. And so they have become the second state to begin universal screening. This will probably be incorporated into their standard panel in 2025. They are doing it now, and it is an active program, but it is a research-based program, but the information is being provided to primary care practitioners to follow up on these babies and confirm the diagnosis of CMV. And then the last green state on the map is Connecticut, and Connecticut passed legislation last year to roll out universal screening of all newborns in that state beginning in 2025. So in a couple of years, we will have 3 states that have legislatively mandated, confirmed universal screening of all newborns for CMV.
This is truly remarkable, and I'd like to congratulate you and the state of Minnesota for leading this huge effort and this incredible achievement. So thank you to you and your team and to the state of Minnesota. Now, how can we raise awareness on a national level and increase this to further states and additional states in addition to the 3 that you've already discussed?
I think just the act of screening increases awareness. If parents know that their baby's being tested, then that in turn increases knowledge about CMV. It's important to keep in perspective that cytomegalovirus is actually the most common infectious disease in the United States and probably the world that causes disabilities in babies. You know, just pause and think about that sentence for a moment, and that's a pretty powerful statement. And yet most pregnant people don't know about CMV. As we do screening of newborns, and to some extent, depending on the circumstances, as Dr. Swamy alluded to, as we screen at least some women for CMV antibodies during their pregnancies, that alone will increase knowledge and awareness. There are things that people can do, that pregnant people can do, to decrease the risk of acquiring a CMV infection. CMV is hard to catch. It's not like COVID or the measles, which are really highly contagious. CMV, you have to have really intimate contact with body fluids. And what's more intimate than a mom caring for her toddler? You know, wiping the toddler's nose, changing the toddler's diaper, cleaning up the toddler's body fluids, as all of us as parents have experienced. You know, the most simple and straightforward way is meticulous, scrupulous hand washing. Hand hygiene and avoiding exposures that might put you at risk can really help decrease the likelihood of acquiring a CMV infection. And so the CDC does have some guidelines and handouts and educational materials that try to provide knowledge about how to prevent infection. And I will just sort of circle back for a moment to the Vivian Act here in Minnesota and lots of other legislation in many other states. Not only does the legislative pathway provide opportunities and options for testing, but legislation in state legislatures also funds knowledge and awareness campaigns. And that's another really important component of the public advocacy efforts, not just testing, but also increasing awareness.
And what better time to access these resources than during the National CMV Awareness Month? Thank you so much. Geeta, along similar lines, how do you raise awareness with your obstetric patients and your obstetric community, as Mark was pointing out?
So I think as Mark stated very clearly, right? So hand hygiene is really the key, right? So it's true. It is not easy to get CMV, except it's easy to forget not to get CMV. That's how I put it, right? So in other words, walking into a room with someone with CMV, you're not going to get it just from simply being in that room, but with that child. But I can say, as someone who has teenagers, right? When my kids were little and they didn't finish something off their plate, or I was drinking something they wanted a sip of, right? You give it to them, and you don't notice that they have a runny nose because they have a runny nose so many days, right? It's just a regular thing. So, but it is why we don't see CMV transmission, say, like in the healthcare setting, because we utilize universal precautions, right? First thing when you walk in to see a patient is you wash your hands. Last thing you do before you walk out of the room is wash your hands, right? Same thing, we walk in and out of a room in the hospital while we're on rounds, right? We have the hand sanitizer, cleaners, right? Washing hands. So it really does make a significant difference, because we know that the most common way that people probably acquire it during years of childbearing, either prior to pregnancy or during pregnancy, is from exposure to those who have CMV, which is usually young children. So it isn't about being around them. It doesn't mean you can't be with them. It's really about trying to reduce your risk of infection in general, to be honest, right? Hand hygiene is really, we know, is proven for reducing influenza acquisition, reducing, acquisition of so many other infectious diseases as well. So.
Thank you. Those are excellent words of preventive wisdom. Thank you. Mark and Geeta, I pose this to either of you. I wanted to ask you, what have we learned from the rollout of the RSV vaccine that's been administered during pregnancy over this past year? How do the two of you feel about this? What are some of your thoughts, very briefly?
Well, I can give a quick start if I just say, it's hard to talk about the RSV vaccine without also talking about the RSV monoclonal antibody, right? And so there's the vaccine that can be administered during pregnancy. There's the monoclonal antibody that can be administered to the infant post-delivery. And I think what's very interesting to me is that the rollout is such that, in relating it to CMV, is that people who came in wanting to know about the vaccine, asking for the vaccine, eager to get the vaccine, were people who had awareness of RSV. Mm-hmm. So getting back to your question about how do we increase awareness of CMV, a lot of people don't know what RSV is either, I will just say. And so it was the people who either had a previously affected child, mm-hmm. had a family member who, a niece, nephew, grandchild, that sort of thing, right? Or neighbor, someone who they knew directly who had a child impacted by RSV. And for the most part, many children have RSV and they do just fine, but many have significant complications resulting in hospitalization. And unfortunately, we do not have a treatment for RSV, right? For active RSV infection other than supportive care. So I would say that the people who wanted the vaccine were people who knew about RSV, which tells me that increasing awareness of CMV could be helpful for reducing acquisition, but also for something maybe Mark might want to touch on is what might happen if we get a CMV vaccine as well.
Exactly. And I will that's a perfect segue to Mark. Can you briefly tell us about the more current updates on the status of the CMV vaccine?
Yeah, CMV vaccines are really a high priority. And sometimes we judge the value of a vaccine in terms of its overall economic and health impact over a lifetime. And when we think about a lifetime of disability caused by congenital CMV that might be prevented by a maternal vaccine, that's a no-brainer. That rapidly zooms to the top of the list in terms of the best bang for your buck in vaccine investments. So vaccines to prevent pregnant people from transmitting CMV to the fetus are really a major public health priority. Fortunately, we have 3 or 4 pretty good vaccine candidates out there in various stages of clinical trials, including a vaccine that's actually in what we call a phase 3 study, an efficacy study that will answer the question of whether or not vaccination of young women prior to their childbearing years can prevent acquisition of CMV infection. And if that's successful, then that will really go a long way toward decreasing the lifelong burden of CMV on so many babies and families. And so I think those of us in the vaccine field are very, very eager to hear the results of that study, and hopefully we can begin to make some headway in this. There's still a lot of issues. We really need to address health disparities issues. We know that there are significant disparities in the prevalence of CMV in newborn babies. So we want equity in the administration of any vaccine, including a CMV vaccine. But one step at a time, we will soon know if any of the vaccines that are currently in clinical trials look promising enough for licensure.
That's very exciting and hopefully a promising future. Thank you so much. And we do have time for a audience member question here. So Dr. Swamy and Dr. Schleiss, is the eradication of CMV infection possible? Not a simple question.
Well, I mean, if we have an effective vaccine that can prevent, so I guess the question here, though, is it eradication of CMV infection or eradication of congenital CMV? Because we might, that, as you know, that some vaccines work differently, and that different vaccines work differently, and that they might prevent a full-fledged infection. They might just reduce the complications of infection, that sort of thing. And those are some of the things we're going to have to look at with the studies that are ongoing. So I'm not sure about eradication of CMV infection. I think if we have an effective vaccine, we could get to a place where we significantly reduce congenital CMV with the hopes that we could, eventually see eradication. I mean, we quite rarely see, for example, congenital rubella. I mean, that's one really good example when you see the course over time that, Ali, of course, you and I that screen and give rubella vaccine, if someone is not immune in the postpartum period. But to date, the only congenital rubella cases that get reported are amongst unvaccinated individuals at recent times. So we could, you never know.
Immunization is very powerful. Yes, Dr. Schleiss, do you have any closing remarks on this topic?
Yeah, well, I mean, I agree with Geeta, and all very pragmatic and very valuable information. I'll play the dreamer for a moment and just sort of speculate a little, because the goal of any vaccine program ultimately is to someday reach a stage where you don't need to give the vaccine anymore because the vaccine has eradicated the disease. So it's a great question from the audience. We've only been successful with one disease, and that's smallpox. But in theory, one thing that rubella and CMV have in common is they're only transmitted from person to person. There's no animal reservoir, there's no insect vector. Those sorts of things make eradication of influenza, for example, which is transmitted throughout the vertebrate chain from ducks and geese and pigs and chickens, and here in Minnesota, cattle. It would be impossible, one would think, to eradicate influenza, but in theory, you could eradicate CMV. We believe that rubella has been eradicated from the Western Hemisphere. And so I think when we put it in that kind of context, knowing that CMV is a hard virus to catch, and knowing that we've had success with other kinds of viruses, it is conceivable to get to the question that eradication of CMV might one day be possible. That's a long way off, I suspect, but it's a very hopeful and exciting idea, and a great way to end this seminar and think about the future of CMVs. Knowledge, education, prevention, which we have ways to do right now by teaching young women on how to avoid the virus, and then one day an effective vaccine. These are the ways to control this very important cause of disability and lifelong injury in babies.
I very much agree, and really resounding optimistic words are very inspiring, I will say. Dr. Schleiss, thank you. And this brings us to the end of our program. I'd like to thank Dr. Mark Schleiss and Dr. Geeta Swamy, along with our wonderful audience members for joining us today. I hope today's discussion was helpful in increasing your knowledge about congenital CMV, and in return, maybe you can share this information with your patients and your professional community to help raise the knowledge about congenital CMV, especially during this National Cytomegalovirus Awareness Month. Thank you all for joining. Until next time.
Thank you.
Thank you.